Mm-hmm.
The advantages is that it is very sensitive and it is applicable to all patients and clone unbiased, while its limitations is that it needs longer time than MFC and it requires diagnostic pre-treatment samples. Now, starting with multicolor flow cytometry, it is a fast and relatively inexpensive method that is broadly applicable to most ALL cases. It distinguishes leukemic cells based on their aberrant immunophenotype or leukemia-associated immunophenotype. A leukemia-associated immunophenotype can include antigen over or under expression, asynchronous antigen expression, cross-linear antigen expression, and ectopic phenotypes. However, these features may change under therapeutic pressure and the antigens may be lost or new antigens may be overexpressed as the leukemia evolves. To overcome this challenge, an alternative flow-based MRD approach named different from normal has been widely utilized. The different from normal approach involves a standardized panel of several markers that are used to distinguish leukemic cells from normal hematopoietic cells. Fresh samples sent for MFC should be processed within 24 to 48 hours of collection, which is why this is an advantage of MFC because it is rapid and the reporting time for clinical results, which may be returned to the clinician within 3 days of collection. Although it may be performed using peripheral blood, the ability to use blood as a source for MRD detection by MFC is limited because of its reduced sensitivity, which, as discussed before, is one of its limitations. Now, moving on to real-time quantitative polymerase chain reaction, chimeric gene fusions are major oncogenic drivers that can be found in 40% of BALL and some TALL cases. Since these rearrangements are oncogenic and they are often stable throughout the disease course, making them good targets for MRD assessments. RT-PCR can be used to track BCR-ABL1, E2A PBX1, KMT2A, and CRLF2 rearrangements in BALL, as well as TAL1 and TLX1 and TLX3 fusion transcripts in TALL. Digital droplet PCR is a third-generation PCR technology, which is based on separation of the sample into at least 20,000 water-oil emulsion droplets, followed by PCR amplification in each droplet. This technique is highly sensitive, which improvement in the limit of detection and does not require a reference curve. Here we can see the two methods that I just discussed, which are qPCR and ddPCR. qPCR and ddPCR can be used to detect fusion in mRNA transcripts in ALL. We can see the difference in the two methods. We can see that the ddPCR does not require a reference curve, which is why it may be easier to do. And to do it, we need to use oil and do partition samples into droplet of 20,000. Moving on to allele-specific oligonucleotide qPCR, ACO qPCR, which we can see in the picture next to it, is how it's done. It leverages Ig and Tr gene rearrangements to detect MRD in ALL. It relies on identification of VDG sequences in a diagnostic sample, followed by the design of patient-specific primers for the sequences. The last method, which is high-throughput next-generation sequencing, also like ASO qPCR, it targets specific VDG rearrangements, but unlike it, it is fast and it is clone unbiased, and it uses multiplex PCR and it does not require the development of patient-specific primers. These are its advantages compared to the ASO qPCR. And here in the picture, we can see how it is done, and we got the curve that can help us with clone tracking. The clinical significance of MRD in adult ALL. Prognostication in ALL has historically relied on baseline leukemia characteristics, including white blood cell count at diagnosis, immunophenotype, and cytogenic abnormalities. Increasingly, studies have demonstrated that MRD response to frontline therapy outweighs traditional prognostic parameters and has emerged as the strongest independent predictor of ALL outcomes. Ongoing MRD monitoring may provide a potential window for clinical intervention prior to disease relapse. Given that the majority of ALL relapses occur within the first 3 years following diagnosis, MRD monitoring for early relapse detection is likely the most crucial during this time period. The conclusion is that incorporation of MRD assessment is a fundamental component of risk-detected therapy in ALL. For almost all patients with ALL, there is a reliable method to assess residual disease, which remains the most powerful independent predictor of outcomes.